Um, yeah.
Awesome.
Court, how you doing today?
I'm doing great, Joe. How are you?
Great. Wonderful.
So
Excited to
nice
dig
of you
in.
guys and you specifically to host this. And I know what a passion project this has been for you for like the whole 2.5 years or so we've known each other now. But like this is such an exciting, for me personally, such an exciting study to see coming out of PHRI. So
Yeah, and PHRI is a research group at UC San Diego. Is that correct?
that's
What's
right.
PHRI stand for?
Psychedelics and Health Research Initiative. And I believe that's soon going to be transitioning to Psychedelic Health and Research Institute, which would be
Great.
super awesome. Yeah.
That's fantastic. Great. And we've, been working on this topic, doing webinars, doing research, and your chronic pain was somewhat resolved, if not largely mitigated, as a byproduct of a psilocybin trial at NYU, right? Like you weren't going there
That's
for chronic pain treatment, but all of a sudden,
no, not at all. I mean, I had a prolonged background in treating clients with chronic pain, as well as performance issues. So often they're coupled directly together. So if you're dealing with, say, on a fairly easy scale, the formerly fit who overdo it when they're trying to return to working out, me too, and then just they've lost mobility, they've lost capacity, they've deconditioned in terms of metabolism and responses and everything like that. Usually there's mobility issues that they have to work around. Almost always that's accompanied by a pain issue. But then I also worked with people with very severe pain conditions like CRPS, complex regional pain syndrome, or phantom limb pain syndrome, or things like fibromyalgia and the like. And those are higher order issues that are mitigated and governed by the central nervous system. And so then you're starting to deal with, like, not that there's a local injury, but there's a perceptual maladaptation. I don't want to say necessarily a dysfunction, because it's part of the protective suite that the nervous system offers, but at a certain point it's no longer useful, and then it is like, yeah, dysfunctional. So
right. So like a lot of the project here, everybody, is what is pain? How do we think about pain in 2022, and where do we want to see pain science expand to in 2023 and beyond? And not to mention science, but the treatment as well. And
yeah,
Court, what was the text on the image you posted today? It's not that we need to.
right. We
It's a
don't
really
have to
great one.
prove that psychedelics are effective for treating chronic pain. We have to establish it's already been proven.
And there's a good amount of research going back many decades here. So
Yes.
what we're going to do is review this one paper. We can do some Q&A at the end, and yeah, we'll get into it. So
I know Uma is out there. Hi, Uma. She's in the audience. She also attended our psychedelics and pain symposium, which was awesome. I believe she's either a postdoc. Forgive me if I'm getting it wrong. I know she's working in a lab somewhere, and very down with this type of research as well. So let me just pull this one up. A little bit of the background around PHRI is that I believe it was right around, let's see, we'll select this. I'm going to keep it simple and go in and out. Can you see it?
Not yet. It's loading though, so we'll get it in just a moment.
Screen sharing is paused.
Oh, fun. So yeah, try to kick it off and start it again.
Do it again.
I've given you permissions.
Okay.
So UC San Diego has a really interesting history, and Ramachandran, the amazing neuroscientist there, did some really interesting work. And a National Geographic, I think, explorer in residence had a serious accident, and they did some mirror box therapy and a few other things. And I don't want to speculate too much here, but this individual actually consumed a bunch of psilocybin mushrooms in the desert outside Palm Springs doing these exercises, and the phantom limb pain disappeared, largely speaking, through, doing a lot of prep, doing the exercises, ahead of time, prepping the nervous system, and then doing it again later. Court, do you want to
That's
mail me
right.
these files or anything? Like, drop them in Slack to me and I can share.
Yeah, for sure. I can as soon as I get this up and running. Now, why is this one showing and not the other? Are you seeing a picture of the brain?
Yes,
Let's see.
yes. So Uma just put a great thing in here. Uma is a neuroscience master's student and grad research assistant in a chronic pain and stress neurobiology lab at the Center for Advanced Pain Studies. Brilliant. Hopefully a postdoc one day, applying to PhD programs as we speak
I
for
have no
psychedelic
doubt she will be an
neurobiology.
awesome postdoc.
Can't wait to see what you do, Uma. Amazing. Thanks for being here.
So just to go briefly on what you were saying, Joe, so UCSD was working with Albert Lin, as you mentioned, National Geographic Explorer. He was also a postdoc there, had a car crash in the desert while someone else was driving. They flipped over, pretty severely mangled his leg. They tried to save it and they pinned it. But eventually they said, hey, we've got all these new hybrid composite artificial limbs. They'll let you get back to action right away. He was a very active man. And you won't recover full capability with your, this remaining but fairly injured limb. And so they're like, okay, let's give it a try. They had it surgically removed, and immediately an intractable phantom limb pain, right? V.S. Ramachandran is there at UCSD. Fortunately, he came up with mirror visual feedback, or mirror box therapy, where you're creating, so there's a phenomenon known as deafferentation. It's a loss of afferent or incoming sensory input into the nervous system. So it's coming out from the peripheral nervous system, feeding into the central nervous system, and then that creates a perceptual output or a motor command. In the case of, and you can see here, we're all looking at this picture of two brains, right? So that red hand is a limb that is going to be lost or amputated or injured. It could be a stroke, it could be cancer, it could even be some this deafferentation or this loss of signal, right? Think of loss of signal, which is an alarm bell. It could also come from something like type 2 diabetes, peripheral neuropathy, or other acquired diseases as well. So, so down here we have the somatosensory strip, but then once that's missing, this is a massive perceptual gap that starts off an alarm signal within the central nervous system. But because we never evolved, is the speculation around limb loss, because usually that meant you were bleeding out. And in Paleolithic days, there weren't a lot of options to stop that, right? So usually results in very significant ongoing pain. So he, we'll get back to this in a second, but he started trying mirror box therapy. Coming up, here we go. He started trying mirror box therapy, and that looks like this, right? You look at the reflected image of the intact limb, and that actually is enough to stop those nociceptive or those painful outputs, the painful perception from the central nervous system. And these are considered conditions of central sensitization. It's pain that's being generated out of the central nervous system, though there's often neuropathic or nerve issues themselves. So here he is. So he tried mirror visual feedback or mirror box therapy, and it would be effective as long as he did it. And then he heard through, I believe, Dr. Timothy Furnish, who's one of the department chairs there at UCSD, why not try, something that induces neuroplasticity like LSD or psilocybin? That's also when there was a lot of strong information coming out of the cluster headache community. So cluster busters, Bob Wold has been working on this for decades, right? Some of the first modern psychedelic studies were around pain, painful headache conditions, and psilocybin LSD. So he takes high dose psilocybin, and that interrupts the pain for something like close to 18, 20 hours, right? But as soon as it wears off, he gets a slap back or a rebound. And this is also known within the cluster headache community, where the pain comes back magnified, right? Magnified, but that's generally seen as a positive sign that the nervous system is adapting. But finally, what he does is he combines mirror box therapy. Here we are. He combines mirror box therapy with high dose psilocybin, I believe at the suggestion of his life partner, his wife at the time. I think it was his life partner, right? So you can look here, the dose response curve for pain reduction when he's taking high dose. So down here on the left, high dose psilocybin, it works, it works, it works, and then it's gone, right? Now he's in pain again. Then over here, we can see where he's combining mirror box therapy and mirror box therapy or psilocybin alone, and you see that this response curve is much, much higher with the mirror box therapy. And then you look at this top slide, after the first application, it goes down. And I should also mention, we'll get back to this previous slide that I first started with. It goes down for 2 weeks, and you can see that on the pain scale, he went from around a 7, 6.5, a 7, right? Though he would have that flare up to far higher around number 8. And this is pain that it's incredibly bizarre and demoralizing. It cannot be ignored. It's like your limb is on fire 24/7. In his case, he felt like he had railroad spikes driven through his foot, right? And they suspect that was a holdover from when they were attempting to pin the structure, his skeletal structure back together in his limbs. So 2 weeks, it drops like by more than half. Then they do another application that gets better for up until the next 5 weeks. Then it just drops off and goes away, right? And that has more or less been his permanent condition since then. Here you can see this woman doing it with her hand. She could have had a crush injury. She could have had something involving cancer, right? There's a shot of a psilocybin pill in a cup. And in fact, that's the very cup where I was a participant at the NYU psilocybin study. But here we are. You can see compare these two screens, right? This is in a very, carefully controlled psychedelic assisted psychotherapy clinical setting. This is a postdoc faculty lounge. That is a table from Costco. So are those chairs. Clearly, this is fluorescent lighting, right? Everyone is crowding around him. It is noisy. Look at the Cro-Magnon skull there on the table. And this is an artificial foot. This is a plastic foot. He is right now on about 5 grams, right? And they've covered this gap where the limb used to be, but they're starting to do things like brush it with a feather, right? And they're starting to do things like, bring an artificial flame, like you get a Halloween novelty store near it. And he is literally feeling the heat from the false flame, right? And it is penetrating and causing deep relief, right? There's also another picture where I believe it's this woman here, who I believe is another postdoc. One of them gets under right next to him and inserts their foot under the blanket where his leg would be and sticks their foot out. And then she starts moving her foot around, right? So under the neuroplastic window that's occasioned.
What do we call that method, Court? It's not mirror box therapy, but it's like a simulacrum of mirror box therapy.
It's like neuromodulation.
Okay,
right? It's sensory replacement using the visual field to access that somatosensory strip. So that's the work that they've been doing, and they've been going gangbusters ever since. So moving on to the study today. They've just released a case series of 3 patients that self-reported to them after they released this work in their 2020 review paper of psychedelics, pain and psychedelics, classic psychedelics, a review and a proposed mechanism of action. So they came out with this case series examining 3 different patients. Let me pull this back up, please. Where is it? this one. Do I have to slide this way? Okay, nope. Yes. Okay, they have 3 patients. The first one is a 37-year-old man with a history of quadriplegia, right? So he had a rollover, another car accident. He had a rollover while he's age 29, cervical spinal cord injury, not great. And so that's very high up on the spine, resulting in complete quadriplegia, no motor function distal or below the thoracic floor spinal level, right? So that's not awesome. And that includes bladder, bowel incontinence, lower, and this is key here, lower extremity neuropathic pain, right? So he's in a wheelchair and he can't get out. So I'm just going to look at a few of my notes over here real quick. And the thing to recognize here is that he takes initially, I believe it's where's the amount? I think he takes the high dose initially to treat this, and he goes from pain he does a 5-gram dose here initially, right? Sorry, I'm just minimizing something. And that results in, it says, near total relief from his lower extremity neuropathic pain that lasted 8 to 10 hours, right? But he's under a full dose of psychedelics. So that's creating a profound psychedelic experience as well, which can be disorienting, of course. So then he decides to experiment with a lower dose of 250 milligrams, and the analgesic effects persist with a similar magnitude of relief, so almost near zero, after being a person who is often experiencing this at say, averaging 4 or 5 out of 10, but intensifies by the end of the day. His baseline of pain intensifies to 8 to 10. 10 is considered to be the worst pain you can imagine. This is a self-reported scale of like, okay, on a scale of 1 to 10, how bad is this pain, right? So throughout the day, he's operating at 4 to 5, which is not great. That is incredibly distracting, incredibly debilitating. But 8 to 10 is like you're immobilized and you're just counting the seconds and the minutes for it to stop, if it does, right?
I want to indicate something about dosing here, Court. So 5 grams is a lot. A quarter gram is not that much. So one of the problems with these figures is it's whole mushroom, and there's a really substantial amount of variability mushroom to mushroom on even like a single like grow area, like a grow surface.
That's right.
So massive variability here. And like so we have some data. It looks like psilocybin was playing a part here, but we don't know what the dose is because we'd have to extrapolate from the whole mushroom. And this is like, there's really serious accessibility concerns here. If we go purely the isolate or synthesized psilocybin, we're going to really amplify the expense, because this needs to be everywhere. If we're serious about this, we need this everywhere, and it needs to be cheap and available. And home grow or like legal mushrooms, buying whole mushrooms is probably always going to be cheaper than buying synthesized psilocybin and or like bioidentical, kind of isolate or whatever it is. So
you're totally right.
That's just something to keep in mind, everybody. When we go through this, the dosing with whole mushrooms is complicated. That's all. Please continue.
They do address it at the no. So it's a great point, and I'm glad you brought it up. So they do throughout each 3 of these case studies, we'll see a response to the dose curve, right? So this dose curve response, where when they're every single one of them, their initial dose is a macrodose. It's a large dose that bears out with a lot of pain studies, that usually the big one first, but they're all maintaining it afterwards with a microdose. And they also go into the variability, the individual variability response for each patient, how they genetically respond to psilocybin, and they have varied pain conditions, but also the distribution of psilocybin within psilocybin cubensis and what they suspect they're likely receiving with each patient. So that's worth getting into at the back. You can see here, though, what's fascinating, and now this happened to me, and this happened to Jim Harris, who we both know as Perpetual Weekend, who's a spinal cord injury survivor as well, who also had profound response after a very heavy-duty physiotherapy program, but then took psilocybin mushrooms in a recreational context and then immediately started getting sensory and motor responses in his previously paralyzed limbs. This person here, so it says, in addition to pain relief, right? And just keep in mind, on the microdose, he is maintaining most of that pain relief, like going from an 8 to 10 or a 4 to 5 down to near 0 for 6 to 8 hours at a time. But he's also experiencing an unexpected side effect of stimulating muscle spasms that is found to be soothing and therapeutic to his paralyzed muscles. The spasms are likened to a form of exercise, improving tone in the paralyzed muscles and strength of non-paralyzed muscles, which facilitates posture and mobility, okay? So, and it's also improving, another improved benefit is to the improved efficacy of his bowel program. Like his smooth muscle in his bowels is activating, right? So, and he denies that there's any other psychological or somatic effects. And he's been doing this for, he's actually come up with quite a program around it. But while the other medications dulled the pain, the psilocybin totally mutes it, reducing my pain level from 5 to 0 on average. He denies any rebound pain or withdrawal symptoms. So like anytime he stops using it, it doesn't create rebound pain that we were talking about earlier. He's also not having withdrawal, and also is not developing a tolerance. That's consistent through all 3 case studies, all 3, right? And the tremoring is something I directly experienced. I had an affected limb. I had chronic pain going into the NYU study, and my leg started intensely tremoring while I was in my session. They were almost ready to stop because they were worried, like, oh God, is this a seizure or something? And it's like, as I'm going into my peak, I literally have to, the PI is interviewing me. He's like, what's up, Court? Do we need to stop this? I'm like, no, it feels like a TENS unit. Do you know what that is? And, so it's, transdermal electro neuromuscular stimulation, right? So you put that on, activates the muscle, and that often is very useful for either getting motor activity going again, which in turn, typically, it gets the muscle twitching, typically will bring pain down. And I've had a prolonged conversation about this with Dr. Monica Verduzco Gutierrez of University of Texas, San Antonio. She's the department chair of physiatry there, specializes in both spasticity as a result of paralysis and other issues and long COVID. But you can look at, and I've talked about this with Jim Harris, that spasming is that muscle attempting to reconnect and get back online, right? And that movement is helping to sort of triangulate where is this perceptual and motor gap out here in the peripheral nervous system. So I think when we look at the neuroplastic properties and the anti-inflammatory qualities and many others, really the cortical remapping that occurs with 5-HT2A agonists, psychedelics in general, I think we're really seeing that happening here, along with the dendritic rearborization, synaptogenesis, spinal density, trunk thickness, things like that. So,
Court, can we back up and look at like the authors on this paper?
Oh, please, sorry. God.
Yeah.
Okay,
so
there we are.
We're quite friendly with Joel Castellanos. But can you tell me about the other folks here?
So I don't know Dr. Lees or Lies as well, or Dr. Yang. I believe Dr. Yang is a I believe he's a psychiatrist, and forgive me, Dr. Young, if I've got that wrong. I believe the lead author is Dr. Liz Lees, and they're all working in the Department of Anesthesiology, the Division of Pain Medicine at UCSD, University of California, San Diego, is quite a good physiatry and anesthesiology school. It's in a top tier ranking. Dr. Joel Castellanos, he's just been amazing throughout, and he is like a fucking thought leader, and just way out there. And his, I believe, department chair and mentor is Dr. Timothy Furnish, who is one of the people that originally worked on that Albert Lin V.S. Ramachandran case study. So collectively, it's a multidisciplinary department organization at PHRI out there at UCSD, and they just released another study the other night that was a survey of all the current clinical trials for psychedelics and which ones have medical applications. So they are hammering, and plus they've also launched their own neuroimaging and psilocybin study for phantom limb pain. So that's an RCT that's just getting underway. I think they've literally just dosed their first patient. So
RCT being randomly controlled clinical trial.
That's
largely
correct. So here we go. Here's our next one. Patient ES, 69 years old, female with a history of complex regional pain syndrome, CRPS, or CRPS for short, right? Secondary to her left lower extremity, that was induced by trauma in 2000, so some type of injury to her lower left leg in 2017. The insidious thing about CRPS is it can be a completely innocuous injury or seemingly no cause at all. And this is a maladaptive response, both in the tissues and at the receptor level down in the limb. Then that goes up to the central nervous system, where it creates an over-the-top immunological and nociceptive output. So it starts treating something that can be so small as if it were a huge, massive injury. You get 24/7 pain. You become hypersensitized to any and all input. So I had a client that was referred to me by James Fadiman with CRPS, who was interested in trying psilocybin. And he had had a corticosteroid injection in his knee, and ended up, as a full-time IT person, ended up on full disability and having to wear shorts and shave his leg because wind going across his hair follicles could induce a 3-day, pain episode. And it's bad pain. It is really debilitating. We've talked with other people within the psychedelic space. Kimberly Jurovieski, who is a former Air Force major, got CRPS, and it wasn't treated in time. Just, typically the limb will swell up, and it will be hotter, and then it will just really hurt. It will be very painful. So anyone out there, if you get an injury, just real quickly, and it's not going away after 2 weeks and it's still painful, often this gets misdiagnosed and drags on forever before they finally get the CRPS diagnosis. And if you act on it early enough with something like prednisone, you can stop it. So, but here we are for people that have it. So this person, if we look at her pain levels, right? So she is, trying to do aggressive physical therapy to restore her active lifestyle, but the pain progressed, and, eventually she gets diagnosed with CRPS, and, her pain baseline averages 5 to 7 out of 10. And it only gets worse with more activity, and unpredictably it flares up, and the flares don't have a clear precipitating event. And it's characterized as a burning pain with associated cramps, spasms, sudden leg weakness. And like when they're saying burning, that's not hyperbole. It feels like the limb is on fire. I worked with a Iraq vet who had CRPS from an innocuous looking injury, and he felt like his leg was on fire 24/7, right? Eventually had his leg surgically removed, and it looked like a whole functioning leg. Had his leg surgically removed in a desperate effort to stop the pain, right? And so over the last 5 years since her injury, her CRPS only worsened with intensity, and then it starts to spread. It spread to her other lower extremity, even though there was no injury there. That's what happens. They're associated in the central nervous system, and that hypersensitization spreads outward. And it made it impossible for have day-to-day living. She's been, she gets into a wheelchair, so it's reduced her ambulation. That has a cost. That has a cost for any of these people, because when you stop moving, that's a loss of mechanoception. Mechanoception is your body's ability to sense where the limbs are mechanically in space and time, and under load and direction and force. And those are very important survival signals. When that goes down, the body, the nervous system responds protectively by increasing your sense of pain, because it's like, hey, what's going on out there? We can't feel anything. So let's increase pain so we become aware there and like kind of update what's going on with that limb. But when you're not moving, that causes deconditioning to the nervous system, deconditioning to your metabolic system, your fitness, obviously, but really the fitness of your nervous system goes down too. So she's not moving. She's tried everything. Like all of these people in this case study, they all went through standard of care approaches, right? So you look here, she's doing physical therapy, acupuncture, yoga, biofeedback, desensitization therapy, nerve blocks, steroid injections, and stem cell injections without success. She's taking standard of care medication, right? So she's taking NSAIDs, right? So that's like, probably medical grade NSAIDs. She's taking opioids, including oxycodone, fentanyl patches, and buprenorphine. Sorry, totally got that one screwed up. She's taking gabapentin, antidepressants, and none of it's working, right? And so that's important to note in this study. And they're doing something in the quality of their writing here. So if you've been following what's going on with, just as an analogy, the DOJ et al., they're doing these speaking indictments, and the language looks very calm and sort of stuffy, but within the language of the law, they're screaming at you, literally screaming at you. This paper is screaming at us. I promise, when you look at the things that they're asserting, this paper is screaming at us. She reported limited efficacy with these medications, and including bad side effects. So finally, sorry, I got to move it forward. She hears about how psychedelics are effective for chronic psychiatric issues, major depressive disorder, treatment-resistant depression, anxiety, PTSD. She takes 2 grams of dried mushrooms, and within an hour, that's also consistent here, high dosing, within an hour, her pain level drops to 0, right? That's consistent with all 3 of them when you read through this, within an hour. So that's a dose response curve right there when you're talking higher doses, right? 2-0. She noted significant psychotropic effects. She was fully tripping, right? So, and the effects continued for 6 hours post-ingestion, which we know about psilocybin, and the analgesia, the pain relieving effects, they last for 18 to 20 hours. That's also consistent what we know about the CAST study from 1964, right? When they did that at Cook County Hospital for people with significant terminal cancer or things like advanced shingles or gangrene, right? There's ethical issues with the way that study was conducted, but people had analgesia, that lasted 18 to 24 hours or up to 3 weeks with terminal cancer. Some of the worst pain that was known at the time, and it was doing far better than standard of care opioids at the time. So she decides to try microdosing because it's very hard to operate with chronic pain if you're like always tripping. That's also consistent with what we know from Bob Wold and everyone in Cluster Busters and that community. Most of them find the majority of pain relief effects are effective at lower doses here. So there becomes a question like, within a pathological population, what is a microdose? Right? So we've seen studies, and we have friends out there who are very on top of what they feel are limited or absent evidentiary values coming out of microdose studies of its effectiveness at all. I think there is a strong case to be made within pathological populations, and perhaps after a macrodose, we see it being able to maintain the effects. And so she switches to 500 milligrams of dried mushrooms. So that's like half a gram, right? I don't even think that covers the palm of your hand, right? And if that, and at that dose, she experiences 3 to 4 hours of 80% pain relief. And if she bumps that up a little bit, 80% pain relief, but without any psychotropic effects, right? And if she bumps that up a little bit to 750 to 1,000 milligrams, it's more profound analgesia, so even better than an 80% pain relief, and it's lasting longer, closer to, where is it? Yeah, 12 to 18 hours, right? Slowly returning back to her baseline. And so this is interesting about the microdosing here, is that they do return to their pain baseline. They do return to their pain baseline, but a couple of these people here, and she finds that after every 10 days or so, she needs to take a 2 to 3 day break because it's causing some gastrointestinal side effects. But everyone denies any withdrawal effects. Everyone denies any rebound pain. Everyone is not showing any tolerability issues. They're not developing any tolerance. They take it, it works. Like, in this case,
and please, everybody, about 5 more minutes left of this, and then we're going to start hitting up questions. So please, questions, comments, like we'll have a discussion starting in about 5 minutes.
So, and the other thing here is her pain baseline isn't changing. As long as she's taking these low doses, I'm going to say low doses, right, of psilocybin, the pain more or less goes away. But when she's not on it, her pain baseline is the same, right? So this one is CRPS. The other client, he found, let's see, I believe, is it this one or number 3? 6 months doing this stuff. So you can just, if we go back, we can also see that first client with the spinal cord injury, using it daily for 6 months. He got off tramadol, Valium, and cannabis because the analgesic effects from psilocybin were so much better, right? So here's the fascinating one. And this is what I've been talking about, as you know, Joe, right? Forever. My assertion, REMAP's assertion, has always been, and they discuss this in here too, psychedelics are an impact booster for neuroplasticity, and we're trying to alter neuroplasticity anytime we're engaging in neuromodulation, exercise, physiotherapy. We are trying to create a neuroplastic change in the nervous system to restore function and to eliminate pain, right? Psychedelics does this on multiple levels, but it is an impact booster for neuroplasticity. So this is a 40-year-old woman, history of depression, moderate asthma. She has radiculopathy secondary to a degenerative disc disease. So that is radiating pain, shooting down her spine. into her legs. And in this case, it's everywhere. Pain is stiff musculoskeletal pain, right? And begins in her low back. It doesn't get better without and it started without an inciting incident, progressively worsened over a 2-year period, and interferes with daily living pretty bad. Her pain is unresponsive to medications, physical therapy, and multiple epidural steroid injections. She gets a laminectomy, which is a pretty serious spinal surgery, has part of her spine removed to remove some compression, hopefully, on the nerve roots. Her ability to move, her functional capacity gets a little better, no change in the pain, no change in the pain. And she finally tries 1,000 milligrams of dried mushrooms, incorporated in a chocolate bar. Within an hour, here it is, within 1 hour, her bilateral radicular pain, as well as her focal low back pain, went from her baseline of 8 to 0, right? She experiences a sensation that she describes as improved flexibility and relaxation in areas that are usually stiff and painful. And during this time, this is key, she takes advantage of the improved mobility and practices her home exercise routines, her home physiotherapy, which in absence of psilocybin did not provide relief. There are so many things out there that almost work, but like everything works, but nothing lasts. And it doesn't quite get traction. It doesn't quite cross the finish line. When it's coupled with this neuroplastic window induced by psychedelics, it suddenly becomes effective. In her case, it continues to improve. So after a single dose coupled with exercise, the profound analgesic effect persists for 2 weeks on a pain level of 0 out of 10. Pain slowly returns over 2 to 4 weeks, allowing her to space out her psilocybin administration by 6 to 8 weeks, right? And then what else? Where is it? During her dosing, pain relief occurs within a 1-month period. She believes the psilocybin affects her 2 types of pain, musculoskeletal and neuropathic, in different ways. Regarding musculoskeletal, her baseline was previously, this is crucial, previously 9 out of 10 after a single exposure. And we are going to see this. And I've been predicting this, and so have other people in this field. After a single exposure, some percentage is in instant remission. After a single exposure, a shift in her baseline to a 7 occurred and persisted for 3 months before redosing was required. On the other hand, the diminution of her neuropathic radicular pain has been profound, with a complete resolution after the 3rd session and has yet to reoccur. So, and it seems for her, it's progressively getting better too, the more often she does it. So it seems to be getting compounded by more being able to couple that, right? Stack that with some type of neuromodulation, some home exercise program, some type of activity or drills. So yeah, that's all 3. There's way more. Their conclusions, their discussions, their intro is amazing, but and this is a conversation I've had with Dr. Castellanos like over and over. Dr. Verduzco Gutierrez has been very welcoming and letting me throw my ideas at her. I've had prolonged conversations with James Close out at Imperial, Dr. Devin Christie, and also the dose response here that we're seeing between macrodosing and microdosing was in the recent survey study of conducted for the Beckley Foundation by Maastricht University Department of Psychopharmacology with Professor Jan Ramakers. And they, in fact, they cite him in here for his earlier cold pressor LSD study. So yeah.
All right, so let's quit screen sharing here, Court, and dig in and take some questions and see what we can do. So first question here, are there any studies with psychedelics and MS patients that you could recommend? My mother's suffering from pain in her nerves for about 1.5 years, coming and going in different parts of her body with different intensity. Yeah, like where would you suggest somebody start reading, Court? Or are there any clinical trials? My guess is no.
To my knowledge, there are none. To my knowledge, there are none. So if you consider that multiple sclerosis, though, is a degenerative nerve condition, right? And it has, you know,
I'm seeing some overlap with phantom limb pain then.
well, with phantom limb pain, also it's to some degree, it's neuroinflammatory. So when we're talking about neuropathic pain, that's part of what's happening here. And multiple sclerosis is a loss of is it the Schwann cells? I'm sorry, the myelin sheaths that are surrounding, Uma, you can correct me, the myelin sheaths that are surrounding the actual nerve fibers. So there's a lot of sensation, not sensation, the signal strength is bleeding out, and it's that loss of insulation causes it's another kind of loss of signal, but it's due to degeneration of the signal itself, if that makes sense, right? So I would suspect, and let me just be, I am not a doctor, I am not a clinician, I am not a therapist, right? I am just someone that has been, you know, I have advanced certifications in neurology, applied neurology, but just to make that clear here. So these are suggestions from things I've read. I have never seen a study show, and you can, there was also a survey study at Imperial conducted by Julia Bornman and James Close of 11 patients who used psychedelics, classic psychedelics, to treat their own pain. Never seen anybody use one of these and had it make conditions worse. 2 people in that study, the pain increased while they were under, but they returned to baseline. So that's just my way of saying, like, in terms of harm reduction, if there's concern around that, there has been no study showing that it has ever made things worse. The other 9 people in that study, all of them were showing similar dose responses, where suddenly we're going from 7 down to 0. I would suggest, if she doesn't have any severe digestion issues, you know, like one of those chocolate bars or something, you know, would not be, you know, the worst thing to try. And maybe start at a
There's
lower
ways
level
to mitigate the GI stuff.
That's absolutely
sure.
right.
Yeah.
There's
and
lemon tech, there's tea.
one of the problems is the drug war keeping us from talking openly about it. That's why,
That's right.
you know, me without a license, I'm willing to go out there and say this stuff because, you know, I can say things that others can't, and you as well, Court. But really, there are ways to make this a little bit more palatable. You can do some instant rice and some spores, and you have your own mushrooms, like probably $10 or less. Well, yeah, maybe that's optimistic. Let's say $30 or less. And then, like, really, you can create your own, you know, medicine. It's nicer to have a specific dose and know it, but you know, we're not there yet. I'm working on it, but and a lot of us are.
You know, I would say, you know, if you look at what some of these other people were doing, you know, they were doing somewhere between 2 to 5 grams, you know, somewhere between that is probably an effective place to start, you know, maybe 2.5, because for it, if they are psychedelically naive, if they've never done psychedelics, right, it would be good to go into the shallow end of the pool first and get comfortable navigating that space. And then if you find going up is useful, that's great. But, you know, starting off with something in that lower dose range of somewhere around 2 to 3, I think is maybe prudent. And we're also just seeing some people find that more than enough if we're talking about pain. That we don't need the same higher end doses that we're seeing in like some of the psychiatric trials and evidence.
So what other questions do we have out there? This is a really complex and nuanced topic. Cool. Yeah, thank you for saying that about MS. And yeah, it looks like we provided some help. Great. So Donnie asks, were there any reports on the trip experience itself making an impact on the pain? So Donnie, how I'm interpreting that is, does the actual, you know, psychological experience, the inner experience, does that have any bearing specifically on pain outside perhaps of the model you're talking about, Court? I'd say maybe.
If you go to the results here, most of them did not report big mood changes. And in fact, one of them, she continued, the one that had depression, pre-existing depression, right? And there is a bidirectional relationship between depression and chronic pain and depression, right? If I had more time, we could get all into that. But she was taking SSRIs throughout. Her pain is improved, and she was able to use psychedelics while under the SSRIs, has not seen an improvement in her depression, fascinatingly enough. But everything else has gotten significantly better. And remember, all three of them are generally returning to baseline when they're not dosing, and they're taking low doses specifically to avoid psychotropic effects, right? I would assert it's great that they did the macrodoses and had the profound relief that they did. I would assert they need more swings at bat to make that lowered baseline sticky. I mean, I would be doing it with some type of applied neurophysiology specialist. It could be a physiotherapist, someone trained in vestibular visual retraining, things like that, and doing it under that neuroplastic window. I mean, we're offering our retreat in November specifically to help people with this type of issue. And we have specialists that have been doing this for years, and we're now learning how to combine all that. But if you were to go to Dr. Castellanos's position paper from 2020, you'll see he has a flow chart at the end for which conditions and how to go about pursuing it. But we've had this discussion at length. We believe in order for there to be neuroplasticity, you need intensity, you need volume, right? And novelty, and I think could be a case to be made for valence, right? So that's what Andres Gomez Emilson from QRI asserts. So, but generally for neuroplasticity, you need intensity, volume, and novelty, and then it becomes salient enough to your nervous system to change. So chronic pain is a long-term condition. Some people might be able to do it once. Some people might be able to do it once and have it resolved, but it's like, it's like a workout. You have to train your way out in the same way that you trained your way into chronic pain, because it is an associative learned quality within the nervous system. You have to detrain it, retrain it. So, I refer to it as remapping, and that's a term of art within those applied neurophysiology communities, for neuromodulation. But
Court, do you have anything on diabetic?
So with diabetes, right? If we look at multiple conditions that have peripheral neuropathy, right? So that is a type of, let's say, somewhat subclinical deafferentation. Remember when we were talking about that loss of signal from phantom limb pain, right? That also occurs to stroke victims, that also occurs to cancer victims or industrial crush accidents. The limb is still there, but because there is a loss of signal, in this case with diabetics, there's tissue damage that's neuropathic, right? I would suspect that could make a big difference. And since that is an inflammatory condition, psychedelics are profoundly anti-inflammatory. I experienced that myself post-dosing at NYU, but that's been something that's been reported on and studied. So Charles Nichols' work on the anti-inflammatory properties of psychedelics is pretty established, and that's also cited in Dr. Castellanos's and PHRI's paper from 2020, right? So I would suspect someone with diabetes, it's not going to hurt. It's not going to hurt them. I don't think so. We all talk about harm reduction when it comes to psychedelics. and people self-treating, and that's great. But I would just share. I've spoken with Eileen Brewer, of president of Clusterbusters, at length, and like in general, there are not that many harms to be found in this type of self-treatment, right? It's usually, in terms of toxicity profile and things like that, it's one of the lowest out there. If anything, it's neuroprotective, it's anti-inflammatory. There's some strong evidence being suggested now that it actually has, in terms of things like atherosclerosis, that it may be, in fact, improving, vascular health. So,
Court, can you pull up the Q&A? There's a question here from Victoria, and I'm really curious what your comments are on this one. You read it out loud if you could.
Oh, sorry. I'm a chronic pain patient, over a decade of pelvic pain from incurable stage 4 endometriosis. I'm sorry. And found a surprising level of relief from ketamine-assisted psychotherapy. Yay! That lasted roughly 2 weeks post-dosing. Do you know anything ketamine as a treatment? Do you know anything, I'm assuming, about ketamine as a treatment for chronic pain, or the use of psychedelics for reproductive disease? Specifically, no. Specifically, no. But if you are looking at a class of pain responses within that protective suite emerging out of the central nervous system, and if you think of endometriosis as kind of an anti-inflammatory response gone wild, and then, hypersensitization that occurs as a result. If you are finding yourself responsive to ketamine for 2 weeks, ketamine is short acting. My strong suspicion is that when you look at Gouldelen's work about critical period reopenings around psilocybin or MDMA or LSD, for sure, here comes Uma. Hi, Uma.
We don't have time for that.
Psilocybin should have a longer response. And if you are working with a pelvic floor physiotherapist, and you doing it during that critical period reopening, so post 48 hours, but say before 2 weeks, some people can do it during, right? But in that post-dosing window, I would not be surprised that you could find your whatever interventions you've been doing to mitigate your pain there, and I am sorry, should improve. A lot of these people are taking these psychedelics and they're not doing anything with it other than taking it, right? But that's what's known as the active versus passive care dilemma. You can't take these passively. You're not getting, let me just say, you're not getting the maximum out of them. Whether that activity is intensely happening beforehand in preparation, during or after, so pre, peri, post, that has to be evaluated on a case-by-case basis. But I would be genuinely shocked if it had no effect for you that way. If you're responding to ketamine, and ketamine has its great analgesic qualities as a dissociative anesthetic, but it's also profoundly neuroplastic as well. So, and psilocybin seems to have both analgesic quality. So sorry, I just got another message from, are we?
So that's time.
We're there, I'm sorry.
So
and
we're gonna do more, everybody. Please stay tuned, tell your friends. This will be on YouTube shortly. We might try to come up with a way to answer these questions in text and just email everybody that registered. So if you want those answers, please register for the webinar. And yeah, we'll be in touch soon. Check out REMAP.
Uma,
go ahead, Court.
What you're bringing up about the amygdaloid complexes signaling pathway on chronic pain. Have you read Greg Corderlab's work on emotional encoding for chronic pain through the amygdala? I jumped up and down when I read that, and I think that directly goes here. We can have a conversation offline, don't worry. I think you're, yeah, and when you consider fear extinction that's happening with the amygdala with MDMA, so psilocybin, blah, blah, yes, to critical. Yeah, I know.
So we're going to do a lot more, everybody. Thank you all for being here and being so engaged. This is super fun. And yeah, I hope we can get everything up there on YouTube or email it to you soon. So thank you, Court. Anything you want to talk about in
Thank you,
terms
Joe.
of events or anything like that?
So REMAP Therapeutics is launching our retreat offering in November 9th through the 16th. We have a team that's ready to work with people on using psychedelics for chronic pain. We're doing it per condition. So each retreat becomes its own cohort that we can then study and analyze and share the data that comes out of that. Also builds community, fosters community building there, and allows us as facilitators and practitioners to focus exclusively on that pain. So our first condition that we're doing is for CRPS in Jamaica, where using psilocybin mushrooms is legal. So we feel that's important for client just keeping their sense of safety and security high. And we're bringing this out, but you can go to remaptherapeutics.com and you'll be able to find our listing for that.
And again, research, evidence informed. It's not like we can't call it treatment. That's not fair to anybody, but we're hopeful, very hopeful.
Yeah, and we are coordinating with researchers out there. So, there's
top tier
there's
PhDs and MDs. So this has been something Court and I have been chatting about for a long time. So it's about time. So yeah, please stay tuned. Sign up for Court's email newsletter over at REMAP, and yeah, we'll do this again, Court, soon, I hope. So thanks a ton.
Yeah, absolutely. Thank you so much, Joe. And I just want to recognize you for cheerleading this, making yourself and your resources and your time and your enthusiasm available for this this whole time. You've really helped run this as far down the field as possible. And I think it's no small thing. It's no small thing. Yeah.
Yeah. Thank you, Court. Yeah. It's
Thank you.
It's going to change the game.
Yeah,
all right, everybody.
It is. Okay.
Joe Moore, Corwin,
right.
signing off. We'll see you on the next one.
All right.
Bye-bye, everybody.
Take it easy. We'll